All right, chapter 38 discusses EMS ops, just kind of as a whole. We've discussed a lot of how to radio in calls, how to handle calls, what to do during transport. This kind of puts everything together. So we're going to talk about preparation for our ambulance call, receiving, responding, transferring, transporting, and then doing the patient handoff to the ED. We're going to touch on when the call is finished and then air rescue if we're involved in a setting up a landing zone. So when we're preparing for the ambulance call, your chapter kind of went over a few different types of ambulance. There's not one set chassis. So the type 1 here with the more truck looking, looks like a pickup in the front and the box chassis in the back, that's a type 1. The type 2 looks more like a van, conversion van. Type 3 has it's all in one unit, so that chassis is not sitting on a pickup like this type 1 was. It's an all-in-one inclusive unit. That's a type 3. Type 4 is a medium duty ambulance, so heavier than our standard ambulances that you probably see on the road. And then our specialty response or our heavy vehicle response. This one in particular is a hazmat response truck. Looks more like a fire truck. So just depending on what service you get on, most of them are going to be those type 1 or 3s, but you will have some specialized services that run different trucks. So ambulance supplies and equipment. So obviously without proper equipment, and without things in working order, things that are not expired, we can get cited. We can actually get fined for that. It can be quite spendy if you are fined for inadequate equipment, for expired medications, expired equipment. And that is regulated by the EMS in the state that you're in. So the state can actually does do inspections, whether it's biannual or annual. And they will come in and they will go through literally pretty much every piece of equipment, all the supplies you have in your ambulance, make sure that everything looks in compliance, nothing is expired. So we need to be well versed on where things are in our ambulances, not only for state reasons, right? State inspection reasons, but we do need to make sure in the case of emergent response, we're not digging all over the place. So making sure that supply cabinets are supplies are in the cabinet they're supposed to be in. When you use something, replace it. Make sure the vehicle's ready to respond, right? Every morning shift, usually, or every shift, I guess, inspects that vehicle, regardless if it was on the previous shift or not. That is your baby now. It is your ambulance. So you're going to inspect accordingly. So we're going to go through the vehicle, all the equipment that's in there, make sure that we have adequately stocked, make sure that there's no equipment broke, anything needing replacing. We have two components of that. We have the vehicle itself, right? So making sure that oil is good, antifreeze is good, fuel looks good, all the lights are working, tires look good, not excessive wear and tear, and then the equipment component. So checking your AED, checking your Lucas device, checking the monitor to make sure we've got, adequate battery charge, making sure that our first in bags, our respiratory bags, all are adequately stocked. Do usually check in with that off shift crew, right? We're the oncoming crew, see how the night went or the day went, see if anything in regards to ambulance operation needs to be recorded or written up. If there was, in case of a malfunction of the ambulance, we kind of check with each other before the shift goes on and off and make sure we don't have to follow up on anything. So all right, receiving, responding to a call. The dispatcher is going to initiate that, that 911 response. They may provide some pre-hospital instructions to the caller, which is beneficial, of course. The quicker that we can initiate care, the better. So if we can do that, the dispatch kind of starts initiating that process. Dispatch also coordinates all the resources we will need, right? We're going to make sure and double check if there's something we think that we might need on scene. We'll radio dispatch, but for the most part, they're going to determine, do we need fire? Do we need ambulance? Do we need police presence there? And they're going to coordinate that response. So we went over this very early in the semester. An ambulance operator, you do have to have a valid driver's license. You do, in most states, have to complete a emergency vehicle operation course. It's usually a 1-day course. We're transporting patients, ill patients. So that's usually required in addition to your regular driver's license. We have privileges granted. It's not just automatic. We are asking for permission to proceed with lights and sirens, to proceed through stoplights, to proceed through, stop signs. So absolutely, it's not applicable if you're not on call. It's not applicable when your own vehicle responding. So even though privileges are granted during emergent situations, you're not immune. So you should keep that in mind, respond appropriately. So if you're going through a stoplight and you don't slow down just to make sure that everyone sees you and you hit a car, there's going to be some implications to that. So just make sure we're using our warning devices adequately. It doesn't excuse us from not being or from being sloppy. Okay, so you can't just assume that people see you, people hear you coming. You still need to follow the driving rules and make sure that you're coming to a slow, complete stop, or come to a complete stop. Even when you're trying to go through stoplights, we don't blow through stop signs. We don't blow through stoplights, just to make sure that that intersection is clear and that everyone sees you. Parking wherever is necessary, yes, as long as we're not, life and property aren't endangered. So if we've got to pull up into a no parking area to pick up a patient for an emergent situation, that's usually not a problem. Proceeding past stop signs and signals, once again, with due regard, making sure that everyone sees us proceeding through that intersection, and then exceeding the posted speed limit. And we talked about this before. Yes, we do tend to speed up lights and sirens, priority 1 responses, but we don't go crazy. So saving a few minutes is not worth possibly getting in an accident and really delaying care and injuring you or your partner. Passing and no passing zones, yes, we can do that. Yes, I have seen that. Once again, we got to be very, very careful with that. When you're coming up behind a lot of traffic lights and sirens, their natural tendency is going to be to veer to the left or to the right to get out of your way. So if we're going in those no passing zones on those on the side there, on the sides, we just have to be very careful doing that to make sure that, the cars aren't trying to get out of our way and then hitting us because they pulled out in front of us. Going against the direction of travel is very rarely used. If that is happening, we've got to go that way. We usually do have state patrol or police presence there to go the opposite direction. So it depends on where you are, but for the most part, if you're going to use lights, you're going to use the siren. It's very rare we don't use them in conjunction. So we don't use it indiscriminately. So if we want to just get through a stoplight to get back to the station for the end of our shift, no, we do not do that. The horn, just kind of allowing a different noise. Sometimes we'll get your traffic's attention. It's a different frequency. So using the horn in conjunction. And then your visual warning devices are your flashy blinkies also. So excessive speed, of course, does increase the probability of a collision. Your stopping distance is increased. It's going to be very hard to stop a heavy ambulance. It does not stop on a dime. So, and especially when speed's involved. So use with caution. We've got to look at times, looking up times of the like what's the most common time of day that ambulances have crashed. It's been in intersections during the day with dry road conditions is the most common. So you would think that's really unusual, but that is the highest factor of ambulance crashes. But so looking at days of the week, of course, right? Rush hour traffic, 5 p.m. traffic, 7 a.m. traffic is going to be quite a bit heavier. So take that into consideration when we're transporting or going to pick up someone. Weather, huge indicator around here in the Midwest, right? We have winter, we have ice, we have rain, we have storms, we have it all here, wind. So weather is, you're going to need to take that into consideration too. Road maintenance construction, need I say more, right? It's everywhere, especially since we get robbed out of construction season for 6 months because of winter. So it's pretty heavy in the summer. I'm constantly getting email updates as to what road is closed where and where we can't go next. So just be aware of that. Watch for the railroads, bridges, tunnels, and of course, schools, buses, our little people running across the road. Be mindful of those buses that stop repeatedly to pick up and drop off students. So GPS is installed on most ambulances. We have what's called a navigator that basically alerts us on the screen that there's a call, and then it gives us a little map to kind of get to see where we need to go. So there is, but like it says, there's no substitute for a good knowledge of your response area. Okay. If I've got to sit and look at the map while I'm trying to get somewhere, that's a huge distraction. Now granted, most of the time when you're on your way to the call, you are, if you're driving, your partner's in the front trying to assist with that too. But just getting to know your area and taking that time, even in, off duty, driving around, becoming familiar is really going to be beneficial. With that said, also, you need to make sure, I know we have phones, I know we have our navigators in the ambulance, but making sure you can still read a map. Okay, we do have paper maps for a reason. Electronics fail. They usually are in the ambulance as well. So just make sure that you can still read maps. Okay, it's kind of an outdated concept, but once again, you can't rely on technology 100% of the time. So minimizing lights and siren hot responses. Usually we're getting some information as to whether this is a priority one or, a priority response from dispatch. Anytime we drive with lights and that loud siren, it increases the risk of our safety and increases the risk of us getting hit. So just minimizing lights and siren hot response. Once again, saving a couple of minutes isn't always worth that, but yes, to try to get through traffic when you have an urgent call, absolutely, that's appropriate to use those lights and sirens. Wearing seatbelts as much as we can. I know it's difficult to do that with patient care. A lot of ambulance services are moving more toward getting some things done prior to going in route. So consider that if it's feasible. If it's not, I get it, but trying to clip those seatbelts on as much as you can to keep you safe. So kind of having an idea of where you're going before your response. And if, like I said, getting familiar with your response area is very helpful. Highway incidents. We are going to watch a video that's wonderful. I love it. It's from the State Patrol and MnDOT. It's called Everyone Goes Home. We want to keep unnecessary units, keep people off the highway. The video is about State Patrol units and emergency response units getting hit on scenes and how easy that can happen. So avoid your crossovers, okay? Turnarounds, things like that. We got to make sure that we're clear of all traffic. Protect that scene. All right. If yours is first on scene, the video will go through how to properly line up and how to properly make sure that your units are where they should be. If yours is first on scene versus if you're coming in later. So that'll be, I think, pretty beneficial when you're new. Your PPE, absolutely. You should be having on any street, highway, you should be having a high vis vest or a high vis jacket on. Once again, you cannot assume that people are seeing you. The second thing is a lot of our uniforms are darker, so not a good combination at night. So get your high vis vest on or your high vis coat on when you're on streets and highways on those scenes. So you have extra caution there, extra precautionary clothing. So cones and flares, if it's feasible, reducing emergency lighting. I know that sounds weird, but we want to get there on emergent response. We may not need to keep all the blinky lights on constantly, depending on, and especially with the number of vehicles being there. I don't think we need to have 8 vehicles with lights on. So Unit placement is important. Usually they will direct the ambulance to, if fire and police are on scene, they usually park us ahead of that accident. Therefore, we can get the patient in safely without having oncoming traffic behind us, because we have fire and police blocking behind us. And then we can leave the scene quite quickly because we are not behind a bunch of emergency vehicles. Backing up, we do avoid backing up if at all possible. If you're in the ambulance, or if you've been in an ambulance in the driver's seat at all, you're going to notice your rear view mirror is pretty irrelevant, kind of useless. I mean, you can see your partner working on the patient back there, but otherwise we have to rely really on our side mirrors and some spotters to help us. So backing up, we try to minimize that if we can. So transferring that patient into the ambulance, making sure that we're taking consideration of weather conditions. As you can see, that stretcher versus ice and snow. Stretchers are very top heavy. We discussed that when we were playing with them earlier in the semester. And they are susceptible to tipping pretty easy. So selecting that proper carry device, whether it's a stair chair or a stretcher, making sure we package up that patient properly for transfer, making sure all those belts are locked in position and there's not a lot of give in between there. We don't want loose belts. Making sure that patient's got enough blankets that's appropriate if it's, really cold out. And it's going from outside on wheeling on that, so it is a little drifty. So, and then being careful, spotting on both sides, assisting your partner, making sure you both are out there when you're loading that patient, taking that extra few minutes to make sure that that patient doesn't tip and that they can get into that ambulance safely. So we are at greater risk in the patient compartment, and because we are working on our patients, and we are getting up like flight attendants do, and doing all the things we need to do. So trying to remain seated as much as we can, wearing that belt and harness if possible, so we can keep ourselves safe. Unnecessary movement, we don't have to. And making sure that all your equipment is secured. Okay, so your monitors sitting loose on the on the bench seat, probably not a good idea. Okay, belt that thing in. It's got a handle. Clip that monitor, that cardiac monitor in. So in the event of an accident, that things that are loose are going to come at you at forces that the car is traveling in. So I don't think we want to get hit with that thing. So making sure that all your equipment is secured in a safe area during transport. So during transport, we're going to continue the assessment, making sure that stretcher is locked into place, make sure your patient's positioned and secure comfortably, adjusting straps, making sure that you can access, if you need to access respiratory, cardiac, that you've got, kind of a plan for that, making sure that those belts you can see them in case we do have to unclip them quickly. As far as loading the relative or a friend, it's going to depend on your guidelines. Right now, we don't, it just depends on where you run. A lot of ambulance services won't really want a friend or relative to accompany the patient in their ambulance. However, minors, your children, your babies, usually the parent does come. So just check and make sure wherever you end up working that you understand what the rules are for that. Right. Make sure you're talking to your patient. Don't just be doing the technical things that you need to do. I understand that's important. That's why they call this, but making sure you get that communication started with your patient, and making them feel comfortable with you and comfortable with the setting. All right, we are going to have to call that hospital and let them know that we're going to be arriving soon. We've been practicing some radio reports, giving them an update on how your patient's doing, radioing your age, sex of the patient, chief complaint, current vitals, any interventions that we performed en route, and how many minutes we're out. So they kind of have a preparation. They have a board that they're going to put you on, or a computer they'll put you on that you're coming in. So your little peds, remember, this entire scene could be really overwhelming for them. Not only is there's sirens and lights and strange people in uniforms they don't know, they've also got a loved one that's hurt or they're hurt. So a toy such as a teddy bear, we usually do carry some pediatric toys or stuffed animals in our ambulances. It can do a lot to get that child a little more trusting and calm. Okay. Remember, small kids do not, as a rule, carry ID. All right. So if we're picking up a child that's unresponsive at the school, don't forget to ask the school the child's name and date of birth, so you don't get all the way to the ED and have no idea who your patient is, because they aren't going to have a driver's license, right? So transferring that patient to the ED staff. Okay, so we're going to come into the triage area with our patient, and we're going to provide absolutely, a verbal report. This verbal report is a little more extensive than just your radio report. Okay, this is the one that you're going to be talking to the hospital staff about, giving them kind of the background more. You can kind of expand on it versus the radio report. Okay, so for example, you've already given in your radio report, you have a gentleman with chest pain. When I go into the hospital and I talk to the nurse or doctor there that's going to be treating them, I'm going to give them a more expanded story. Okay, this male patient has chest pain. He was out mowing the grass. He hasn't been feeling well for 3 days. He's got a history of hypertension and he's a diabetic. The chest pain started 3 hours ago. He didn't, nothing would relieve it. We gave him aspirin, we gave him nitro, we did an IV, and so forth. So that report's going to be a little bit longer. That's when you're going to expand on pretty much sharing your OPQRST or your, in your sample history. So I've got an example here, just a short example of a handoff report.
Who's going to be giving me a report?
Me.
All right, is the patient stable?
Yes, yes.
All right, can we get the patient ready to move, get the MIS report?
50-year-old male, single gunshot wound, right lower quadrant, entrance only. GCS 15, BP 164/92. Sinus tag at 118, respiratory rate 22, 99% on room air, point of care is 132. Has a VTOH, he has a 14 in his left AC with the leader up. No allergies, history of high blood pressure.
All right, can we get the patient moved?
Ready?
No.
1, 2, 3.
All right, can we get the primary survey first?
Pain airway, press down equal bilaterally.
So,
Awesome. So as you can see, you got, they're doing the same thing we all are, okay? They're starting their primary assessment, checking airway, breathing, circulatory, and so forth. So the primary and secondary assessments you're learning are going to carry through from our pre-hospital to the ED. They're going to run the same type of assessments, and they're just going to add, their layer of expertise. So all right, so we have dropped our patient off. We have transferred the patient, gave the report, got the signatures we needed from staff and patient if patient is responsive. Now it's time to terminate the call. So when we are at the hospital, we do remove all of the sheets, pillowcases, anything the patient was on. Hospital has laundry bins, and we drop that. Wipe off, clean off our cot, and replace the linens at the hospital. So if we need to go right back into service or do a pickup from the hospital for transfer, we're ready to go. En route to a station, or if we're clear, we're going to radio the dispatch, and we're going to say, if our ambulance number 647, we are clear of the ED and ready for post, right? Or ready, where would you like us? Right. So when we get to our post, or if we get back to the main station, if we have not already, got rid of linens. We're gonna do that now. Clean any equipment if we have not already wiped it down at the hospital. Replace equipment that we have used. So if you use non-rebreathers, nasal cannons, whatever you use, take the time to replace it. Okay, that way the next time it's ready for you to use for the next patient, or it's ready for the next crew to use. You know, and I like how it says prepare yourself for service too, right? This is the time to breathe. All right. If you have a few minutes, get a nice bottle of water, get a snack, make sure everything's ready to rock, make sure you've got fuel. And then if time permits, let's get that patient care report written, because the soonest you do it after a call, the better, because it's what has happened with that patient's really fresh in your mind. And so it's going to be a lot easier to type up information or type that patient care report versus waiting until, the nth hour or waiting until the next day, right? Then you got to remember what all happened. So. Okay, let's talk about air rescue. So why do we have air rescue? Well, speeding up transport. All right, if you've got something out there, it's pretty rural, it's going to take you a little while by ground, where, air is pretty quick. We have a prolonged extrication. All right, so the golden hour, the trauma golden hour, extrication does chew into that. So if we can get a helicopter there, it's not that we couldn't transport them, but extrication's eating up time. Air rescue could be on the ground and standing by, and we can zoom them right to the hospital quite a bit faster and start making up for time lost with extrication. If patient is rescued from a remote location, right? Our big rigs can't always get into everywhere we need to get into. So sometimes it might be a little easier for those birds to drop down and grab those patients. So clinical reasons. I like this first one. Patients in shock. Well, I think I already told you that like most patients are in shock, but when we're looking at shock, we're looking at, severe shock. Your Glasgow scale, coma scale, GCS is less than 10. Altered mental status with head injury, chest trauma, respiratory distress, penetrating injuries to the body cavity, amputations, extensive burns, serious MOI, post-cardiac arrest with a pulse, right? We want to get them to definitive care, see if they need stents or what they need. So how to call for it? Well, most of the time you're going to call dispatch. If it hasn't already been auto-launched, there are some counties that actually auto-launch depending on the mechanism of injury. So if auto-launch has happened, great. If you're not sure, you're going to just absolutely radio dispatch and ask if a helicopter has been launched. Okay. Try to get your landmarks as close as you can. All right. GPS coordinates might be a little harder, but with phones, we might be able to get that. But most of the time, dispatch knows where you are and they're going to handle that. So if you are thinking about air rescue, just radio dispatch and ask if a bird has been launched, or if you need, if you're requesting one. You may need to set up a landing zone to assist air rescue, or you may need to call fire to come out and do that if you're busy with your patients. You need to look at where you are. Sometimes where you are isn't going to work for that helicopter to drop down. Just depends on what we have for wires, ditches, wind direction. We may need to load the patient and move a little bit. So become familiar with where you've seen air rescue have to drop down. All right. It's not always going to be perfect that way, but if you have had like some calls I've noticed over here that especially in a small town, when I was on the BLS service here, we would have a couple of places that we would designate to be helicopter worthy. One was in the church parking lot, one was in the high school parking lot, because there was no overhead lines there. And it was a nice flat area with no trees, no blocking. So just be familiar with some different spots when you start your service area. So when we're coming up to the helicopter, when we set up what's called a landing zone, they need 100 by 100, okay, 100 by 100 of space to load that, or to drop the helicopter down. As you can see from this, we never approach that helicopter from the rear. Okay, never do that. The tail rotor spins. Sometimes you don't even see that rotor, spinning rotor so fast you won't see it. You can kill you. So the danger area is from the back. There should be no reason really why you should be approaching that helicopter anyway. But if you're coming toward it, because usually what they'll do is they'll come out of the helicopter and go toward you. Okay, so never from the rear. If you are coming from the front or you're walking up toward that helicopter, make sure you're getting eye contact with the pilot. All right, making sure that you're not approaching that helicopter until it is down on the ground and it's been disengaged. Okay, follow the direction of the flight team and the pilot. All right, they're going to give you that safe okay to come or to approach. Make sure you protect your patient. All right. If you've ever seen a helicopter land, debris, dirt, dust flies everywhere. So if someone can partially cover that patient or get a sheet to partially cover eyes, nose, mouth, or if you're there in the back, your ambulance already, shut your ambulance door because there's going to be debris flying all over. Okay. So any questions, as always, let me know, but that will complete our chapter 38 tonight. Thanks for listening.